all familiar. Sarah is a household name with ourselves at the moment. Sarah works as the primary care clinical advisor for the National Screening Service. And Sarah, as always, thank you so much for facilitating our webinar today.
Thanks a million, Debbie, and welcome to everybody. Thanks so much for joining us. As Debbie mentioned, this is Cervical Cancer Prevention Week, and so we're going to talk have a little bit of a focus today about the fact that we can prevent cancer, cervical cancer, and as a result of that, that we are on track to actually eliminate cervical cancer. So we'll talk a little bit about what that actually means. In 2020, the World Health Organization announced its plan to support every country around the world to make cervical cancer an extremely rare disease, so to eliminate it as a public health problem. And the way that they support countries to do that is by looking at the three different things that we have available to us to help to prevent cervical cancer. So they are vaccination, so HPV vaccination. And what the WHO worked out is that if 90% of all girls in a country were fully vaccinated with HPV vaccine by the age of 15 years, and 70% of women were screened with a high performance test, so that means a HPV test, by the age of 35 and 45. And if anybody was identified with cervical cancer disease, so pre-cancer or cancer, that more than 90% of them, if they receive treatment, that by doing those three things, having this three-pillar approach, that actually a country can get its cervical cancer rate below the level of 4 per 100,000 people. So that is the WHO's definition of the elimination of a disease as a public health problem. And I suppose just the slight difference to think about when we're talking about elimination is that it's not the same as eradication, where you would have no cases of the disease. So unfortunately, we'll never get to a place where we can have zero cases of cervical cancer, but we can certainly make it a very rare disease in every community. So that's what we're all striving towards, and that's what we want to support. And the reason that we can do this is because we know about the connection between human papillomavirus, or HPV, and most cervical cancers. So as you'll all be aware, the last 30 or 40 years have given us lots of scientific breakthroughs in relation to HPV. And we're now pretty sure that persistent HPV infection is the main risk factor for nearly every single case of squamous cell carcinoma of the cervix. And overall, because there are other types of cervical cancers, but overall, you're looking at 90% or more of cervical cancers being related to HPV. And so therefore, if we can tackle HPV, we can tackle all of those cancers. What we know is that the HPV virus is extremely common. It can affect all people who have all kinds of sex. So it can affect anybody in any community. They generally, if when we have HPV, we don't have any symptoms from it. For most people, our own immune system will clear it away within 12 to 24 months. So having HPV by itself isn't necessarily a problem, but it is the persistence of HPV that can lead to HPV-related cancers. We do know on average, in general, it will take 15 to 20 years for a persistent HPV infection to cause cervical cancer. So because we know it's a virus that causes most cases of cervical cancer, then I suppose we know that vaccinating against that virus, using effective vaccination against that virus, is going to reduce the amount of circulating virus in the community. So you might be aware that the HPV vaccine first came into Ireland in 2010 for girls in first year, and that was the HPV-4, so it covered 4 different HPV strains. But since 2019, now all first year students, male and female, are offered the HPV vaccine. We do want to get our vaccination rates up above 90%. We're not quite there yet. And we do know that there was a fall off over the years due to misinformation and difficulties around that. So we are still trying to combat that. There is a catch-up program available this term, so from January onwards to June, to catch up any 5th and 6th year students who didn't get their vaccine in first year. So the schools program is out there trying to get them vaccinated before they leave school. And there will be catch-up offers then for the other years from September onwards. So we also know that the endorsement and support by GPs and general practice nurses around the decision to have the HPV vaccine or to give it to a child is really important. So we would ask again, just making sure anytime that HPV comes up, so ideally around the time of a HPV cervical screen, but any other time, just helping parents to make that choice for their child, or again for an older child, if they're over 16, they can make this decision themselves. As it is now, it's a single dose of Gardasil, which is HPV 9, so you're covering 9 different subtypes. Now, if you're immunocompromised, the regime is slightly different, but basically one shot in first year, and that's going to give you lifelong immunity. And as I say, it's really important that we head towards, I'd get over the 90% uptake rate. Looking at some other risk factors besides HPV for cervical cancer, and these can be important to remember. For someone who smokes, their chance of having persistent HPV increases significantly. So we're all aware that we can all get HPV infection, but it is the persistence of HPV infection that puts us at risk. And if we smoke, it is more likely that our body won't be able to clear HPV itself. So supporting people to quit or reduce cigarettes will really help, particularly if they're found to have HPV on their screening test. There are other situations of specific immunosuppression that make it more likely that somebody will have persistent HPV or that it will go on to cause cervical cancer changes. So these would be people living with HIV, people undergoing renal dialysis, and those pre and post organ transplantation. So in those specific cases of immunosuppression, a person will need additional screening or additional support depending on their HPV positivity. And then there is a very small subgroup of people who are at increased risk of a different type of cervical cancer, so clear cell adenocarcinoma. And these would be daughters of women who are given diethylstilbestrol in pregnancy. That would generally have been in the 70s, 60s, 70s. And so many of these women are getting a bit older now. This is unrelated to HPV infection. This is to do with the risk from the DES, and they are generally managed in a specific clinic. So having a look at how cervical cancer develops can again help us to think about how we manage when people come for screening. And really, if we think about it, the cervical epithelium, this is it on the left here, looking normal, just general squamous epithelium. And what we know is that with a HPV infection, the cells can undergo a process of koilocytosis. And this is where the cells change and become atypical. And this can progress then through from low-grade changes of CIN1 changes through to CIN2, CIN3. And then when it breaks through the basement membrane, you're looking at invasive carcinoma. So this is a slow progression over months and years where cells are moving between different states. At these early stages, at this koilocytosis CIN1 stage, in the absence of HPV, if the HPV clears, these cells are very likely to regress or return back to normal. This is why when somebody might present with a CIN1 presentation or change, that actually we know that watchful waiting is reasonable, that this may actually regress by itself. As things progress through to CIN2, CIN3, then the likelihood of regression gets a little bit less, the likelihood of progression increases. So this is the point at which we would tend to have definitive intervention in terms of colposcopy, treatments, LETs, etc. And what we want to avoid where we can is getting to the stage of invasive carcinoma. But this is a process over time that has movement back and forth, particularly in these early stages. And that's where we want to catch people at. So when we look at the benefits and harms of screening, we know that every screening program is a balance of risks, benefits, and harms. And there is no screening program that can find all cancers without fail and never have any false positives. So when we're looking at the benefits, so these ones on the left, the green ones weighing down the scales, we're looking at a reduced number of people who get cancer being identified earlier, more treatment options, reduced morbidity or ill health in people when they do have cancer, and ultimately reduced cancer deaths. The potential harms from screening come from overdiagnosis and overtreatment. So identifying somebody as being at high risk when in fact they're not, when they might never have progressed on to a significant disease process. False positives. So again, thinking that people are at higher risk of disease, and it turns out that they're not. So sending them on for colposcopy, and then it turns out that in fact they were not at increased risk in the way that we thought they were. And I suppose possibly a little bit more famously, false negative screening test results, and these will happen in every single screening program where the test will come back as negative, but it turns out that that person does in fact have increased risk of cervical cancer. There are negative physical and psychological impacts from all of the above. So being involved in any kind of healthcare interaction, as we all know, can be stressful. And so finding out that you've had a treatment you didn't need, or finding out that you didn't get a treatment that you did need, all of these things can be psychologically and physically harmful. And when we're talking with people presenting for screening, we, again, we need to emphasize the limitations of screening, remind them again that screening simply cannot prevent all cases of cervical cancer. Some people will still get cervical cancer, even if they've come for regular screening, what we call interval cancers. Some abnormal cell changes will be missed. It is not possible to find every abnormal cell change, and that it is possible, of course, to be test negative for HPV and still develop cervical cancer, particularly cervical cancer that isn't HPV related, but also there is a possibility that you could have a HPV related cancer and have tested negative for HPV in the past. And just a reminder, an interval cancer is a cervical cancer diagnosis that happens between screening tests. This can be very difficult for women if they have been attending for regular screening tests and then they are diagnosed with cervical cancer. And we know it can be hard for people to get their heads around that. And we do support people then to have a review of their screening. If that is a situation that happens to them, they might want to find out more about why that happened for them. And that is something that the program supports through our personal cervical screening reviews. So let's have a look at, I suppose, the main function of Cervical Check as an entity. And really what Cervical Check does is that it calls and recalls people who are eligible for screening. So it maintains this cervical screening register, which identifies the eligible population for cervical screening. And we do that through a collaboration with the Department of Social Protection. So basically the register receives a database of all people who are registered as female with the Department of Social Protection and are aged between 25 and 65. This database is regularly updated, which means that your eligibility or whether you're due for your test is updated extremely regularly. People can register themselves if it, for whatever reason, it happens that their information doesn't come from the Department of Social Protection through directly to the CSR. They can register themselves online. And then the program then will send out a letter to the home address as per the address that comes from the DSP. It's really important to remember that the result that the person receives will go to the address that's written on the form. So whatever address initially brought the person into you, whatever address then ends up on the form, that is the address that the result of the test will go to. So it's so important to get the address right when you're writing it on the cervical screening form. The program will let the person know when their next test is going to be due. So it'll be in 3 or 5 years, depending on their age. And a person can always remove themselves from the register themselves. They can choose to not participate in cervical screening if they don't want to. Or sometimes that can happen through their GP as well. And we'll talk a little bit about that. It is important to note that a person with a cervix who is registered as male will need to contact Cervical Check directly to be registered on the CSR, because as I say, it's people who are registered as female with the DSP that will come through on the database. The Cervical Check also maintains a reminder and a fail-safe system, and this is to ensure that people get the appropriate and correct follow-up. So these fail-safes and reminders are triggered when a woman fails to attend for her screening test when she's due. So she gets 2 reminder letters. If she has been recommended to go to colposcopy for further investigation, but she doesn't attend, then both the woman and her GP will be sent a reminder, and her GP will be asked to complete a fail-safe return form, which shows that the woman has indeed been contacted and she's aware of the referral and that the referral has been made. If there's a known reason why she can't or shouldn't attend, then that would be included in the GP's fail-safe response. Women and their GPs are also contacted if she doesn't attend for a recommended repeat test after 3 or 12 months. So again, we'll talk about why you might come back in 3 months or 12 months for your recommended repeat. Or if she doesn't attend her next screening after she's been through a colposcopy treatment. So when she's been discharged from colposcopy, and if she doesn't show up for her next screening test after that, both the GP and the woman will get a reminder letter, a fail-safe letter. There's a few things to remember about accessing cervical screening in Ireland. You don't have to have a letter. So we've talked a lot about invitation letters, but if the woman is eligible, she can have the test done. And again, you can check the eligibility online on the hsc.ie cervical check website. And we recommend that that is done every time that somebody is making an appointment, just to make sure that they are actually due their test. The other important thing to remember is that a woman does not have to be a registered patient of your practice in order to have a cervical check screening test done in the practice. When you sign a cervical check contract, you agree that you will accept patients from outside your own patient cohort to simply just attend for the cervical check screening and not to join the practice for any other reason, or not to register as a patient, but just to have their cervical screening test done. That's there to provide people with choice if they have a particular reason why they don't want to attend their own GP or their own general practice nurse. They do have the option of attending any other clinic that provides this service. We make people aware that they may be waiting longer, that we strongly encourage people to attend their own GP practice if they can, because of continuity of records and all of that. But as I say, it could happen that somebody might choose to go elsewhere, and she can have a look at the cervical check website, and any registered provider there should be able to offer her a screening test. And again, if somebody is new to screening, they've never had screening before, they come in and they ask for a test. By virtue of doing the test and sending the test to the lab with the completed form, then she will be added to the register. And again, her call and recall will come out automatically then after that. So just a quick case study, just going back a little bit on that, what I mentioned about going to a different GP practice than your own, because we know this can cause a little bit of confusion. So we had a case where a woman was due for a screening. She had her own reasons for not wanting to go to her GP. She called up a different clinic on the GP, on the cervical check website. And when she spoke to the receptionist, she was refused the test because she wasn't a registered patient. The woman herself became quite upset about this and then contacted Cervical Check, I suppose with a complaint. And what happened was that unfortunately the receptionist she spoke to wasn't aware of these contract obligations, that somebody can come just for the screening test. And again, we recommend that practices maybe have a specific information or script that they would give to people to explain that it is just coming for the screening test. So what can happen in this case, of course, is that woman might just give up. She might just not bother trying to have a screening test done anywhere. And again, unfortunately, because it's contractual obligation, you could actually be in breach of program guidelines by refusing the person. So it's really helpful to just make sure that every member of staff in the practice is aware of this, that somebody can phone up for a screening test. So we'd often get asked by women, how often should I be tested? So the age range is between 25 and 65. Occasionally people might end up having a screening test after 65 if their previous one was abnormal. And it is 3 yearly between the ages of 25 and 29, when we know HPV prevalence is at its highest. So you're most likely to be HPV positive between up to the age of 30. So we do the tests 3 yearly from 25 to 29, and then 5 yearly from 30 to 65. If you get a HPV positive result, but there is no sign of any cell changes on cytology, then you are requested to come back in 12 months' time. If you're HPV positive and there are any abnormalities on cytology, you'll be seen in colposcopy. If you've been seen in colposcopy and discharged back, then there are specific algorithms that the colposcopists use, which will trigger then invites to the woman to come back with, say, 12 monthly or every 3 years, depending on the diagnosis that they had in colposcopy. So we mentioned a little bit about those populations that might need increased screening, and just to reiterate, they are very specific cases of immunosuppression. people who are pre and post organ transplant, people who are on renal dialysis, and people living with HIV. So people who are immunosuppressed for other reasons, maybe medication, if they are on medication for rheumatoid arthritis, for skin conditions, any of the other multiple medications that people can associate with immunosuppression, they don't actually increase your risk. And so your screening happens routinely the same as always. It is just in these specific cases that we would change the screening routine. There are some populations that do not require screening. And I suppose the most basic one of those is if you don't have a cervix, then you don't need your cervix screened. And the reason that you might not have a cervix is if you had it removed surgically through a total hysterectomy, or if you were born without one. We'll talk a bit more about hysterectomy because there's just a few caveats with that. The other situation would be after pelvic radiotherapy for any reason. So for bowel malignancy or any other malignancy in the pelvis, if you've had radiotherapy, then screening is not recommended. Some people will obviously choose not to participate in screening, and that is their personal choice. We would always make sure that the person has had enough information to really weigh up correctly this choice, and we would like to support them with that. And one of those situations can be if somebody has never been sexually active and they would be considered low risk. It is really important, though, just to support the person that to understand that any kind of sexual contact is sufficient to transmit HPV. So it doesn't have to be penetrative heterosexual sex. It can be any kind of sexual contact. And the other thing to remember is that unfortunately, many people will have had sexual contact that was unwanted and uninvited, and that can possibly have happened to them at quite a young age. And possibly they may not be understandably comfortable talking about it, or for some people it might be very difficult for them to be aware fully of what happened. So we would always be a little bit cautious about saying that somebody has never been exposed to HPV without being very, very sure. So that is a sensitive one, but it is important to remember that your risk of HPV is related to any kind of skin-to-skin contact of the genital area. It does not have to be full penetrative heterosexual sex. Sorry, now this slide has got a bit askew, but so just talking a little bit about the hysterectomy, we said there's a couple of considerations with that. So she comes in, she's had a hysterectomy 10 years ago, and she had a screening test in 2012 and it was normal. And now she's arrived in to say, do I need another screening test? And the most important thing that we need to find out is, does she have any cervix at all remaining? Ideally, we will know this because we will have a lovely clear discharge letter from her operating surgeon, and even better that the letter is going to include the histology of the organ that was removed at the time of the operation. So if we know she's had a total hysterectomy, her cervix was entirely removed and her histology was normal, then we know she does not need any further screening. She doesn't have a cervix, she's not at high risk, and she can be removed from the register and taken off the screening list. If she had a subtotal hysterectomy, and we know that the cervix or a bit of the cervix remains, then she has a cervix, she still remains at risk of cervical cancer, and she should be screened as normal, just following the normal routine. And so if she's had a total hysterectomy, we need to fill in a hysterectomy data collection form, which will give the information about the total hysterectomy, and she won't get her invitations anymore. If she's had a subtotal hysterectomy, she has her screening test. So it's the normal screening form, and you're ticking cervix because she has a cervix, and you're ticking subtotal hysterectomy because that's what she had. And then off it goes to the lab, and she's recalled then according to her result. And this is just the hysterectomy data collection form. So it's just taking details of her details and the fact that she no longer needs screening because she doesn't have a cervix. When you're looking at the screening form and you're filling in hysterectomy details, so the woman has had a hysterectomy, when you tick on the form cervical screening test information, and there's a bit there that says sample site cervix, by ticking cervix, you are confirming that you have visualized the cervix, you've seen it, and that you've put the brush around the cervix 5 times. You've done a complete sweep of the cervix 5 times, and then that is going off to the lab. When you've clicked cervix, the only other thing that you could click if she's had a hysterectomy is subtotal, because the only way she has a cervix is if she had a subtotal hysterectomy. If she had a cervix, if she had a total hysterectomy, therefore she doesn't have a cervix. If she had a subtotal hysterectomy and you're clicking vault, That is also incorrect, because if she had a subtotal hysterectomy, she should still have it. She does still have a cervix, and you can't click vault if somebody has a cervix. If they have a cervix, you need to visualize the cervix, see it, do your 5 sweeps, and send off your test. So then why do we have the vault box at all? If we're saying if she doesn't have a cervix, then she doesn't need a screening test. So why are we even thinking about doing vaults for somebody who doesn't have a cervix, therefore doesn't need screening? So we'll go through that just a little bit. So there are some situations in which we may need to do a vault screening test from somebody who's had a total hysterectomy. And they are basically, if somebody has had a total hysterectomy, we don't know the histology. So we don't know, was there any signs of CIN in the cervical tissue when the histology was done? In that case, the program recommends that she would have one further HPV test taken from the vault. And then if that's negative, then she doesn't require any further screening. So this is basically to assess her risk. She doesn't have a cervix left. There's no tissue left. And she doesn't have HPV. So her risk of developing any kind of, even if there was small, tiny cervical cells left somewhere, she doesn't have HPV, so she's low risk. If in her hysterectomy histology, it turned out that she did have CIN, but they weren't, maybe somebody wasn't expecting it, or anyway, when they did the histology, there were signs of CIN, then she is at high risk because she's already had CIN in the past. And in this case, she will need specific screening at 6 and 12 months, but that would be a shared care situation with colposcopy. She's no longer being screened. She's actually in a surveillance situation because she's already had disease. So she's not somebody who's in the normal population with no symptoms, no disease. She's had disease, she's at higher risk. So those are the situations where a GP might be taking a vault test for somebody who doesn't have a cervix. So again, coming back to this, if you find yourself moving towards the vault box to tick it, and oftentimes a reason for that might be maybe difficulty finding the cervix, even though she's supposed to have one. So she hasn't had a total hysterectomy. We know there's a cervix there, but we can't find it. If you cannot see the cervix, don't take a screening test from the vault. You can refer her to colposcopy to find the cervix. Sometimes it might be maybe related to discomfort, postmenopausal discomfort. Sometimes it can be positioning. There can be a couple of different things that we could do that might help. But do not be tempted to tick a vault box if the woman has a cervix, because the lab will not do the test. The only situation in which the lab will do a vault test is if she's had a total hysterectomy. So just looking a little bit at women who, and we know that this can happen quite a lot, that somebody might actually come in for their screening test and they have symptoms. So we formulated a kind of a guidance note in relation to this, just to make sure that it's easy and clear for people to understand what we do in that situation. But we have it in a little algorithm here, which is a little bit easier. So if somebody comes in with abnormal vaginal bleeding or other symptoms of cervical cancer, and she's either coming in asking for a screening test, or you're wondering about whether you should do one or not. Basically, you would obviously take her full history and have a look at her screening history, but then you're doing an examination, a speculum and a pelvic examination. If her cervix looks normal, or maybe that there's some benign pathology there, cervical ectropion, something like that, you would take her screening test only if it's due. So it happens to be due. There she is. Her cervix looks normal. You're going to take the test while she's with you. If her screening test is not due, do not take the screening test. So screening test is not a diagnostic test. It is nothing to do with her symptoms. It is not going to help you evaluating her symptoms. So if her screening test is not due, and again, you can check the eligibility online there while she's with you. If it's not due, don't do the test. If, when you look at her cervix, that it doesn't look benign, so it looks suspicious for malignancy, even if she's due her test, we would recommend that you don't do the test, that you would refer her urgently to colposcopy, so that she would be sent. And again, if you have a suspicion, clinical suspicion of malignancy, phoning up the colposcopy unit, she will be seen within 2 weeks for an urgent case like that. So occasionally what can happen is that if a test is done, sometimes there might be a delay waiting for the result of the test. We know that the test could be normal and the woman could have cervical cancer. We also know that sometimes it could happen that somebody would rely on a normal test and say, well, if it's a normal test, then it can't be cervical cancer, and that is something we want to avoid. So if you have clinical suspicion looking at cervix, send her to colposcopy. This is just reiterating that, don't take the test, refer her urgently to colposcopy. If you identify a benign pathology and she's due her test, you can go ahead with it. If you're not sure about the pathology, but you're pretty sure it's not malignant, then again, sometimes you could discuss this with your local colposcopy unit, but only do her test if it is due. Um, and again, if somebody is coming in looking for a test, but that is not due, so they'd say, "I'd like my test done now," to the doctor or the nurse, and you say, "Well, you're not due for another 2 years." She's like, "Well, I really want it now." We really just have to dig into that a little bit and make sure she doesn't have symptoms, because we know a lot of the time people might come in looking for a test when in fact they have symptoms, and that's what's kind of prompted them to make an appointment. A screening test has no place in diagnosis. It is not a diagnostic test. It is no use to you in diagnosing abnormal bleeding or any unusual symptoms. So some of the challenges that people can come across when they're dealing with sample taking, one of the first ones is with our screening form, and we have tried to change this to make it a bit easier. There are two boxes that you're putting details into. One of them is the box for the contracted doctor, so the doctor who has the contract with Cervical Check. This is basically for your payments. So you're putting in the identifiers for the doctor with the contract in the contracted doctor box, number C, or the section C. And then section D is for the person taking the sample. That might be the same person. You could be the contracted doctor and you could be taking the sample. But more often than not, the sample taker might be a nurse or a doctor who's working under the clinical governance of the doctor who's contracted. So just make sure you get the right details in the right box. Another issue that can come up is in relation to the use of lubricants, moisturizers, vaginal estrogen. As we know, many more women are using these kinds of products, thankfully, to maybe alleviate symptoms of menopausal symptoms, etc. But just an issue to watch out for is that some of these products contain something called carbomer, which is a chemical which apparently can sometimes interfere with the HPV test. So we would recommend that if you are using a lubricant, just check to make sure that it's carbomer free. We have some on the list there, and we are trying to update our list all the time, but it is challenging because sometimes it can be hard to get the right information even from the manufacturers. But going with one that you're confident doesn't have carbomer in it. If you do need to use lubricant, you may not need to use it. And then the other thing is to advise women not to use any of their own vaginal products for 2 days before they come in. So just to say to them, if you generally do use a moisturizer or a lubricant or some other product, just to not use it in the 48 hours before they come in for the test. That just ensures the integrity of the HPV test. We mentioned earlier a little bit about having difficulty viewing the cervix. These are just a couple of tips that we have that might make it a bit easier. So we know that perhaps making a calm environment, if people are tense or stressed out by the environment, that can make the positioning a little bit more difficult. It can be helped to change the speculum size. Sometimes if you have collapsing vaginal walls, what you can do is to use a glove, cut off a glove finger at the top and at the bottom, pop that over the speculum, and then use that to keep the vaginal walls open. Using the left lateral position, putting her fists under her buttocks, making sure you have good light, and then always maybe asking for help for a colleague. If it's not working out for you, it might work out for a colleague. And again, like that, if you're having a lot of difficulty, our colposcopy colleagues are happy to support us with that. If there is a difficulty with the sample and it goes off to the lab and it can't be adequately tested and it must be repeated, you do need to wait 3 calendar months afterwards. We know that after menopause, the cervix can change quite significantly, and we do know that a lot of women can suffer with genitourinary syndrome of the menopause due to estrogen deficiency. So we would strongly support for women themselves and for their own comfort the use of vaginal estrogen, but particularly if you're having difficulties getting a good cervical sample, it can be really, really helpful for the woman to have even up to 3 months or more of vaginal estrogen before the test is done. Remember, a cervical screening test is never urgent because the person doesn't have symptoms, there's nothing wrong with them. So waiting 3 months is absolutely fine. And again, you're very familiar with this in terms of treating GSM. So all of the possibilities that might be there in terms of vaginal estrogen and the use of moisturizers, etc. So after the sample is taken, off it goes to the lab. If it is HPV positive on the first test, then it goes to cytology to check the cells. If the cytology is negative, then it is repeated. Sorry, I've lost my slide there. So if cytology is positive, then she'd need to go to colposcopy. If the HPV is negative, we know she's at very low risk and she can come back again in 3 or 5 years, according to her age. When results come back, they'll be sent to the woman. So they'll go to the woman within 4 weeks of having her test done, and they'll also come to the GP via Health Link. Any non-negative result needs a consultation, so whether that's by phone or in person, but anything that isn't a negative HPV result requires a consultation. So to explain to the woman, you're HPV positive but cytology negative, we need you to come back in 12 months. You're HPV positive and there are some abnormal cells, you'll be going to colposcopy. These need to be discussed through with the woman. We strongly recommend that you'd have a practice protocol and a log, so that keeping track of all the samples that are sent, making sure that all results come back and that they're managed appropriately in terms of onward referral, in terms of the fail-safes, etc., etc. The types of results that people might get, as I say, the most common is going to be HPV not detected. So up to 9 out of 10 people are going to get this result. And then HPV detective cytology negative when they need to come back in 12 months to see if they're still HPV positive. HPV detective cytology positive, where they need to go to colposcopy. And then it can happen again that it might be inadequate or indeterminate, or sometimes there can be incidental findings, or the test might not be processed because of a difficulty with the form, with the vial, with labels being missing, those kinds of things. So those are the possible results after a test is sent. We mentioned already about repeat tests. You have to wait 3 calendar months. And this is the computer is very strict about the 3 calendar months. So whatever day she had her test done and you know that she needs a repeat, count 3 calendar months after that date for her to come back in again to have the repeat test done. If it happens 3 times that it is inadequate, then she will need to go to colposcopy. Our electronic referrals are rolling out to all colposcopy units nationwide. Each individual practice will have its own kind of protocols about referrals. But at the present time, when you're making an electronic referral, you still need to add the full lab result as a PDF. So you save down the lab result as a PDF and attach that as an attachment to the electronic referral. We mentioned about the fail-safes. You can do those online or in a paper form. So a letter will come through to you to say your patient has not arrived at colposcopy, or she has not come back for her repeat test after 3 or 12 months. And so then you can log in online with your own clinic ID and her CSP ID and then fill in the fail-safe there, or the old-fashioned way is the form. So this is the bit that actually comes out to you in the post from Cervical Check. You can fill that in by hand. So you're putting in to say whether she's pregnant or whether you have been in contact with her or her address has changed or whatever. So again, just talking about cervical cancer, which is the thing we're trying to prevent, and the symptoms that we want people to watch out for at all times would be unusual vaginal bleeding after the menopause, after sex or between their regular periods, changes in vaginal discharge, pain or discomfort, or unexplained pain in the lower back or pelvis. We really want to get it across to women that no matter what their screening test was or is or will be in the future, if they have any symptoms, they need to come and attend and speak with their GP about their symptoms, because then they need a diagnostic pathway. They need to have those sorted out. Thankfully, many of us are actually not going to end up seeing cervical cancer that often in our surgeries from now on because of cervical cancer elimination. And what people will say is that, you know, when, like with lots of cancers, when you see it, you sort of know that this doesn't look good. So the cervix will tend to be friable, tend to bleed very easily, might be sort of craggy and rugged in appearance. And like that, if you're not sure, you absolutely can ask colposcopy for advice. We do have a visual assessment guide on our education website, and we have an image library of the vulva and cervix, and lots of different resources, because we know that sometimes people can be a little bit uncertain, what am I exactly seeing here? So we include lots of benign pathologies as well as cervical cancer. So we're going to just quickly go through that. So the person who has the contract with Cervical Check is called the clinically responsible doctor. It is their responsibility to make sure that everybody who is taking samples is registered appropriately, and that they're also with their own professional body, but also that they're registered with Cervical Check as a sample taker. And each CRD, each contracted doctor in the practice, if this, then we'll say, for example, there's a nurse and she's taking samples and there's 3 doctors in the practice, she needs to be registered under each of the 3 doctors. If you are retiring or choosing to step back, you need to inform Cervical Check 6 weeks at least before you're leaving. And as you're probably all aware at this stage, there is what we call this introductory module. So this education module that we're providing in lots of different ways through these webinars, and also available online at any time. That is a contractual requirement to complete this. And any sample taker can also undertake an accredited cervical screening education program, which is a more comprehensive program, which has theoretical and clinical components. And certainly anybody new who's starting with sample taking will go through the cervical screening education program, but we would recommend it as well for people who are experienced sample takers who may, first of all, hopefully find it enjoyable, but also will help with their practice. Anybody who's taking a sample, and I mentioned this already, you need to be registered under each clinically responsible doctor in the practice. If your details change, you need to update them with the program. Only take samples if you're qualified to do so and it is within your scope of practice. We would strongly recommend monitoring your own practice with an audit. Looking at your own personal training needs. Our screening training unit are fantastic. We have clinical trainers all around the country, more than happy to help to come to the practice to give anybody any bit of advice that they need in terms of cervical screening. And again, just all of those things we were talking about in terms of protocols, follow-ups, all of those kinds of things. This is our cervical screening education programs, as I mentioned, one for novices, people who've never taken screening tests before, and another one then for experienced sample takers. Highly recommended. Free, no charge at all for any of this. We know that some people will find it more difficult than others to attend for screening. So again, just thinking a little bit about maybe people after menopause, we mentioned about GSM and vaginal estrogen. We know that LGBTQI plus people will find it harder to attend, and it can be helpful to have something like inclusive posters and language around the practice. Trauma-informed practice is really important when it comes to cervical screening, and we have an education module specifically about trauma-informed care, and again, highly recommended. We'll also be sending out what we call our tip of the month. So just as a small summary of the advice that we would give around trauma-informed care. We have lots of easy read materials. We have videos. So for people for whom English isn't their first language, for people with literacy issues, we try and make all of our information as accessible as possible. We also have an access officer, which people can contact as well if they have specific needs. And I suppose just to reiterate, we have all of the screening tools and the vaccination and the treatment tools in Ireland to be able to reach our global targets that we spoke about before. When we do identify cancers through screening, we know that 80% of them are detected at stage 1, which is obviously going to be a significantly different journey for a person compared with a further stage. And, we're going to be able to reduce the risk of cervical cancer. We're not going to get it to zero, but we will get it very close. And what we as healthcare professionals can do is to support people around screening and in vaccination, make sure that we are informed of latest updates, and then be familiar with our own specific patient populations. If we have particular people at risk within our own patient populations, to think about ways that we can help them to make the choice to participate in both screening and vaccination. And that's our 90, 70, 90 goal. As I say, we are very close to getting there. We aim to have eliminated cervical cancer as a public health problem in Ireland by 2040, which is only 14 years' time. So babies born this year will be getting their HPV vaccine at a time when cervical cancer is extremely rare. And that will be thanks to all of the combined work of all of the people involved. So thanks very much. That is the email.